across. I think, Tanya, are you going to share them?
I think she shared it to everybody, as far as I
She
know.
said she'd share it on the screen.
Okay, let's see whether she can definitely share. Okay, all right. Okay, so go ahead. She has given a health system. Okay. I think so that's the way she has put the page on. Uh,
Okay.
okay. You can go ahead and explain, so everybody will be a better listener if you go ahead.
Okay. I would like to say that ASHA is just an abbreviation for the term accredited social health activist. So there are criterias over which a ASHA worker is selected. A ASHA worker does not have a fixed salary, so they get paid according to the work that they do. And a ASHA worker is just not a female health worker. There are male health workers as well, and their functions are different with respect to collecting blood samples for malaria, and the functions of a male ASHA worker cannot be done by the female. Whereas we have more female ASHA workers, so they can communicate with the females of the village, as it becomes easier for a female living in the village to share her issues with a female ASHA worker. So I read through the criterias or
You
how?
can go. You can give it briefly, step by step.
Okay. Okay. So for the female ASHA worker, she should either be married, widowed, or divorced. So the reason being here is because a married female would understand how a married family, a fully functional family in a village would work. For example, if a single female, that's what we've been taught, that if a single female becomes an ASHA worker, she cannot connect to the village family as a married female can. She should be a resident of the village, so even she knows what are the pressing issues and the prevalent issues of the village. Her age should be between 25 to 45. There is a criteria for her minimum education, but again, there are females who haven't studied at all. So if I don't know if that's mentioned, but if she's an 8th pass or a 10th class pass student, it's fine. But there are criteria where we've even chosen a 5th grade female as an ASHA worker, and she's selected by the Gram Panchayat. So basically, what she does is she goes to every household. I'm talking about the main home-based postnatal care, which you give after pregnancy. Postnatal is post-pregnancy. So she visits every mother after delivery, and she checks if there is any bleeding, if the mother has fever, if the baby is breastfeeding, and this is more important when they have a C-section done than a normal NSVD. So there are a particular number of visits a ASHA worker has to make to a house with a lady who's just delivered a baby. And as mentioned below, if it's in hospital delivery, they have to visit the house 6 times. And if it's a home delivery where it's assisted by a midwife, that's the patient is seen 7 times. So the ASHA worker is someone who actually spreads awareness, is someone who educates the family, or mainly the female of the family, about what kind of diet modification should they have, what if they're having a sedentary lifestyle. She'll mention about the changes in their lifestyle which should be taken. She's the one who distributes your iron, folic acid tabs, calcium tablets. She distributes condoms. She distributes paracetamols and the common prevalent diseases like malaria and TB. So the Nishai kit is a pregnancy detected kit. So we all have seen those pregnancy tests. So she distributes that and she tells the female how to use it so she can know if she's pregnant or not. And Nikshai is the TB reporting and follow up by private and government doctors, which we are supposed to go to the villages and do. And the ASHA worker comes along with us, and she's the one who actually tells us if she has seen any symptoms or if she's aware of any household having a patient with TB. There are a lot of yojanas which we have spoken about in one of our Zoom meetings, where there are reforms which our Prime Minister has started. So we have yojanas like Ujjwala, Ujjwala, which might sound a little confusing because it sounds really similar. But Ujjwala is where they give every family a free LPG cylinder with one-time gas for every BPL family, that's below poverty line family. Ujjwala is preventing child trafficking and helping them in rehabilitation. Uh, there is this person called as Kailash Satyarthi who started a Bachpan Bachao Andolan. That means, so Bachpan is childhood, Bachao is saving the patient, saving the person, and Andolan is like a reform,
Movement.
a
Movement.
a movement started by Kailash Satyarthi. With respect to these yojanas, a ASHA worker does keep a check as to if the government has supplied these uh, criterions followed by the yojanas. So they go house to house and they ask the household if they have been supplied by what was promised to them. If not, then they're given whatever is now provided to them. She is the one who implement. So every government health program is basically evaluated and implemented by the ASHA worker as per how she goes house to house and keeps a check. She celebrates a nutrition day every month. So where you I don't know how many of us how many of y'all are aware with these tapes. In India, we call it Sakir tape. So it has yellow, red, and green color on the tape. And then you take the mid-arm circumference, and then according to the value of the mid-arm circumference, we know the value of malnourishment in a kid.
Mhm. Okay.
So that has been done as well. So the ASHA worker basically gives you a health plan. She prepares the village action plan with the panchayat, and she assists the mother during delivery. So she doesn't do anything of what is practically done by the midwife or the nurse or the doctor, but she's there to support the female. She prepares a list of all the children and their vaccinations and all the antenatal care to be given to the mother. She does not get paid for, okay, so we have a particular pattern. There's a schedule for the vaccines or the immunization, as I call it, for every child born in India. So, ASHA worker gets paid for every vaccine she gives to the patient. So, only the first vaccine, that is the OPV, BCG, and Hep B, which is compulsory by the hospital to give to the patient. So, apart from that, she's paid for all the vaccines she has been given to the patient as per the child. So, the ASHA worker cannot conduct delivery. She cannot make the malaria slides because that's what the male health worker does. So, only the males are allowed to make the malaria slides. And one ASHA worker is there for 1,000 people. So 1:1,000 is the ratio for ASHA workers. Unfortunately, India has 9.54 lakh ASHA workers when we need 13 lakh ASHA workers. So we're lacking ASHA workers in the villages. According to the uh, pyramid, the ASHA worker has to report to the nurse and the health worker or the multi-purpose worker, and then they present the information to the sub-center. As mentioned, one sub-center should be for 3,000 people in a hilly region and 5,000 for the plains. With respect to the sub-center, we have two types, and both the sub-centers have different functions. Only type B can perform delivery as they have more staff members. There's a fixed amount by the government allotted for every worker, may it be the doctor, the nurse, the ASHA worker, given to them every month. And the amount of beds, the amount of staff workers, the amount of equipments, and everything is noted down, and there is a particular number which has to be followed. We have basic tests done at the sub-center that includes urine, albumin, urine sugar, blood pressure, weight monitoring, blood sugar, and hemoglobin, and the weight measurement for every pregnant female also. And according to their values, we give them the folic acid tabs needed, or if they have any further tests to be done, they're pushed to the higher level, probably to the CHC or the PHC. It depends on the doctor per se who thinks what diagnosis the patient would have. And do I talk about the PHC, or do we just see how the
you can, why don't you talk about PHC? That's very important. We have covered the CHC and other one. So you can talk
yes.
about PHC. That will be beneficial. Go ahead.
So, as I mentioned about the sub-center, so sub-center and PHC. PHC is primary health care, primary level of health, which is a little above the village route. In theory, both are at the same level. That's what we've been taught. So PHC has an MBBS doctor. That's how we have med school for 5 years. The doctor is called an MBBS here. But the sub-center does not have an MBBS doctor. So the PHCs are of two types, type A and type B. And type A has less than 20 deliveries, type B has more than 20 deliveries per month. And there are 3 nurses in type A, and type B have 4 nurses. One PHC should be there for 20,000 people in a hilly or a forest region, and 30,000 people in a plain region. So PHCs have 6 beds, 2 delivery beds, 1 NBC, that's your newborn care corner. And PHCs have 13 to 14 staff members. Again, PHC is the place where you either have one MBBS doctor or one Ayush doctor. Ayush is an abbreviation for Ayurveda, Yoga, Unani, Siddha, and homeopathy. These are the other types of medicines which we have already mentioned in one of our meetings, which India follows. And any graduate from the Ayush body can be present here. And there's a fixed salary for the MBBS doctor and the Ayush doctor. Because there are doctors who don't want to work in a village, they've uh, recently spoken to the Medical Council of India, where they have mentioned that we need a hike in our salary for us to work there, because already the lifestyle and the availability of a village is really less for a person to go there and stay. They just wanted more salary. So that's what they've requested. Basically, a PHC has 4 pillars. There are 4 bases on which a PHC works. That's your community participation. How well, it's basically just teamwork. How well do you help each other? How well do you educate each other? You spread awareness, and how well do you actually follow what's been told as a team? It's how we function as a family individually. It just, a village just functions as one whole big family together. So that's community participation, where every week there's cleaning in the village. There are activities ASHA workers hold in a village, which everyone takes part in. Then there's intersectorial coordination, where we have hand pumps or standpipes, and there's Anganwadi improvement. So I think in one of the meetings, we had spoken about how cholera is also very common in the villages of India. And so these are the times when we have the hand pump or the standpipe improvement, or the Anganwadi workers improvement, where they pay more attention to how the water has been supplied. Is the water clean? Is the food provided nice? And if it's hygienic. Third point being equitable distribution. So every household should get equal amount of facilities provided by the government. And D being appropriate Sarkis tape, that is the nutrition tape which I had mentioned, and the WHO ORS, which I believe everyone knows the composition of. So the work of a PHC, or the main elements of the PHC, are to educate about the local diseases, and every place has its own I hope everyone knows what an endemic is.
Hmm. Yes.
So every place has its own disease more prevalent in a particular village. That being the first, to educate about the local diseases. Second, the local diseases treatment. So there are areas in India, villages which flood every year. So they've been told to actually not walk bare feet, to not just roam around bare feet, because leptospira is very common when we have floods. It's very easily spread during those times. Third being essential drugs. So there are entirely 288 drugs which every PHC has to have. It's just compulsory for them to have, because they're the most common drugs which we as doctors prescribe to these patients in the village. Fourth, M is for maternal and child health. So as we spoke about ANC and postnatal health care, that's been taken care of. E, essential vaccines. So we had spoken about this entire mission called the Indradhanush mission, that is rainbow. Indradhanush in English means rainbow. So as the rainbow has 7 colors, Indradhanush, the mission has 7 vaccines which are mandatory to be given by the government of India to every child. And these 7 vaccines are of the diseases which are preventable. At birth, we have 3 vaccines given. That's your OPV, that's your oral polio virus, the BCG, and the Hep B, hepatitis B. N for nutrition. So we have midday meal mission here, where you have 1/3 portion of proteins and I think 1/2 of carbs provided in every meal to a child. And they're a very minimal rate. Like I think they're at like 5 or 6 rupees, which a child has to pay to have a meal there. So that's a new thing which the government has started as well. T is for treatment of emergency. So we have a triage. For example, if there's a disaster which takes place, or if there's extreme conditions where we have a war or a terrorist attack or such cases, we have a triage where we divide patients into black, red, green, and yellow. So black, the color black signifies the morbid patients. So no health committee team goes to the morbid patients. They're just left. Red is for the patients who need surgery within 6 hours. So they're the ones attended first in scenarios of a disaster. That can be flood, earthquake, tsunami, any of those. Green is where the patient's already ambulatory, so a patient can take care of himself. Yellow is the one who needs surgery from 12 to 24 hours. So they're the next which are attended. So it's red being the first to be attended, then yellow, then green, and black is just left. So that's where we have T for treatment of emergency, where they attend which patient first comes into that criteria. S being safe water and sanitation for hygiene. And nowadays, there are a lot of NGOs which have started going to villages and, like educating girls about sanitary napkins and hygiene during your menstrual cycle, which is really important, because that being the main reason why females in the villages uh, have more health issues, for poor sanitation and health hygiene regions, and safe water to prevent cholera, and just to keep a proper lifestyle and health. So we have lab tests done at the PHC, which have CBC, that's your complete blood count. You have TB and malaria. Malaria slides are submitted by your male health worker. AFB and ZN smear is your, it's all pathology. Your ZN smear is basically your Zeal Lensil smear, which we have for all your lepre diseases. And we have AFB, that's for lepre and TB. Urine microscopy and routine examination is done. And beyond PHC, so this is where we finish our PHC, but beyond PHC, we have a CHC and we have a district hospital. So this is basically the pyramid which the Indian health system follows from the village root level. I think that would be
Oh, wow.
the
What a great way you have put together everything. I'm so glad that she touched that part. So we can stop the sharing the screen. And wow, okay, everybody's here now. Uh, look like everybody awakened from what she had talked about. Uh, uh, so she basically got us information. What is the role of ASHA worker? How the ASHA worker is selected? Most of them are female. They have an honorarium, but not paid in a large amount. But they also given payment when they do the work in the field, giving the vaccine, taking the pregnant woman, and getting them delivery. So as Meera Dani talked about PHC, not PSC, CHC, and we also had an interview about medical college. So this is at the ground level, what they call sub-center, and she talk about PHC. So below the sub-center at the village level is ASHA worker. Government has an elaborate plan. And I remember back in 1972, 73, when I become a MBBS physician, UNICEF had a plan at that time. And I volunteered for 3 months to go in the villages. And I still remember that I decided to go by a private transportation to the center. And from that, UNICEF had given us a vehicle. So this thing about going to the villages has been there. Uh, uh, Good things he has brought to us is they are aware of a lot of endemic diseases. Tuberculosis is one of them. Lot of this consider what we call a gastrointestinal disorder, diarrhea and other one, which are endemic. Uh, the other part of endemic diseases, which we talked about yesterday on this, lot of skin diseases because of the poor hygiene. Anemia, it's a, I will consider is a unique way, whether you put it a disease or it is a, due to malnutrition or lack of education, you can put anemia in all different categories. So we had a good kind of introduction and explanation. So we will have, do you want Tanya to Kriti to talk about it before we open and talk and question answer? What do you think?
I think either way is fine. We can do questions or critique and talk. Either way is fine.
Okay, what everybody want? You want Kriti to talk now or uh, what do you want to go ahead?
Kriti is talking about soap notes, so that's a little different topic.
Okay, so let's, uh, anybody had any questions about what we call a ground level government operated healthcare services which can reach to the village? See, talked about village level, but ASHA workers are also in urban setting. We have not touched it because at ACL, we are dealing with a village level setup. So we will not touch that. And there are people they call facilitator, which are above the ASHA worker, which are at 30,000. There must be a one facilitator, which has been talked about in the literature. Did we share that ASHA worker article I sent you, Tanya?
I think we
Uh,
did like a lot earlier, yeah.
yeah, there is a website by Government of India. Is called Vikaspedia, VIKASPEDIA.in or whatever. You can go and Google it, and you can pick up the language, which language you want. So that's good. Uh, let's see the questions from anybody. We can
I
start
had
with,
a question.
go ahead.
So since they come from the government, sometimes aren't villagers uneasy when getting help from them? So how do you um, treat them?
Let's, okay. What's Dr. Bora has anything to say about when they don't trust the government?
So the thing with villages is that even if they don't trust the government, they trust the doctor which is available. So every village, because now I don't know if you recollect, but I spoke about how we have to sign a bond or contract with the government where we have to work there. So every doctor, every village has a doctor present there. And there's
Mhm.
just not one doctor. So there are at least 2 to 3 doctors because we go for duties for 24 hours a day. And then we have a 6 hour shift the next day. So the next day when I have previous, I have my co-colleague working there for 24 hours. So one of us is always there at the village route level. So
Oh,
even if they don't trust the government, I'm sure they have some doctor or a nurse which is always there to help.
I think Mukta brought a good point, but at the same time, government has really extended the services by different yojana. Yojana means different way there is availability of services. And because of government now offers all these different services at no cost to them, definitely they doesn't have too many options. Yeah, they might be reluctant in some situation, but what we have seen that they basically are reaching out uh, to Asha worker because she can come to your home. It's like having a service to your door. Good question. Anybody else want to see question? Go ahead,
I have a question.
Aditya.
So I was gonna ask how many people, how many women that want to be ASHA workers get rejected, because if India is such a large like need for this amount of ASHA workers, why have a selection process that rejects people because you're in need of so many? So I was just wondering what that amount would be like of people rejected. And if there's a way to increase like the amount of people being selected if there's such a large need for that.
Good.
Um,
Go ahead. Uh,
so, firstly, uh, the work that an ASHA worker does, I think any female at the village round level can do that work. Secondly, we do not, so we just reject an ASHA worker if we see if she's not fit for as to how the other ASHA workers are functioning. We, the thing is, we're that needy for more ASHA workers that we do not reject the ASHA workers, to be really honest, because we're anyways lacking ASHA workers. So the procedure to reject is just if they're not fit to function or if they're not functioning to as how we need them to. But we just need more and more ASHA workers, which we do not have at present.
okay. One of the thing what I read about article that it is all this is a central government program, but operated and kind of done through a state level. And every state have a unique kind of selection process. And there are some kind of bottleneck, I would call it bottleneck. And that also becomes a challenge to select. They have to select from the village and they have to have this criteria and lot of cultural issues come. There is some political issues do come. So there is always this kind of going on. And many of them may join, but they drop out too, because it is something, if you don't like it, you are not going to hang on too long. Uh, so good question. Any question you have? Uh,
I
Go
had a
ahead.
question.
Go ahead.
Yeah, so since they're government workers or at least affiliated with, do they have a more clear career path, you could say? Like after becoming an ASHA worker, do you think it helps their chances of being employed maybe as like a part-time nurse or something afterwards? Is there any kind of career path for them afterwards?
Uh,
They
okay.
So
Go
with
ahead.
respect to being a nurse, there's a proper course which every person has to go through. How we have a med course for doctors, they have a nurse course as well. So to become a nurse is not something I've heard of, not that I'm aware of. And the chances are really bleak because they need to be a nurse, you need a lot of hand-on practice as well. you're basically just working with the doctor and for the doctor. So a ASHA worker is, I honestly, like, they either from the village they might become your urban health worker, which is the National Urban Health Mission, which we've started. So from National Rural Health Mission, where ASHA workers are appointed, we have NUHM, where we have urban ASHA workers. So that is the maximum promotion I believe they can have, or they can become Anganwadi workers. So that's about it, but there's no more that I'm aware of or I've heard, because being a nurse is just, it's a very different route to be taken than what a ASHA worker is doing.
Uh,
So yeah.
good. Good question, Mana. One of the things they have that they can grow up to be a facilitator. Okay, so that salary increase is almost fivefold for them, but they have fixed salary. They may not get other part. That second part is when they have called sub-center or PSC. There are some openings to work there. Uh, Basically like a nurse's aide or other one, where you do not require that kind of lengthy course or nurse. Uh, and it's very good point you brought. I remember lot of these kids who are 8th grade up to that, they have no clue and they do not take the science subject in 9th and 10th grade. So they are rigidly not have any chance to enter into the nursing program. Government has done a unique thing in some places. She brought about urban area that those girls, or especially girls, or even boys can join who are age 18 and above. They can go to the residential school for 6 months. Government will pay for it, and they will take adequate training in urban setting. They will take urban setting, and they can come back to their town, or they can get employed in the city, because there is a huge demand for those what we call a basic nursing course. And there they can get this is 6 months, but yes, if you have advanced nursing course, that requires longer period. So good question you have asked. uh, Anything else?
I
uh,
have
Yeah.
question.
Um,
I have okay.
Go ahead, Meena.
Yeah, so in the PHCs they also check hepatitis and HIV, right? So I just want to know what's the follow-up like for those diseases that you need to like have a continuous program. Who follows up with that and like that sort of stuff.
Hmm. Good. uh, I don't have much detailed information. What she is telling us that some of this endemic diseases, they basically have facilities available to check it. So a person is symptomatic, let's say he came down with jaundice or other one, I'm sure that they want to check whether this is infectious, which is hepatitis A, or whether you got hepatitis C, hepatitis E, I don't know how much they check it, and hepatitis B. Some of them are communicable, different method. One of them are transmittable somehow, but basically government has these things offered. As far as I know, and last time when I visited, even at PHC, a lot of these things are not easily available for checking. Either they are lacking a what we call trained lab technician. Even making a blood smear is not
I
easy. It does
actually
require
now
good.
like yeah, about a year ago, like this was a recent PHC visit. I went about like a month ago, and for like a year they've actually been doing rapid like Hep B and like HIV tests. So like I think they do it at every center. I'm not too sure, but
Okay.
like I was asking more about like the follow up process. Like how is that done?
I don't
Um,
think so. Go ahead, Dr. Bora.
so, with respect to what Meena, say,
Go ahead.
yeah, Meena said that we do have Hep B and HIV tests. So we have Yojana's particularly for those two. But the follow-up, so every patient has its own stage, or its own his or her own level of the disease. So as per if we're at PHCs and we're working as doctors on duty, we see the stage or the level of which they have the disease, and then we push them to the CHC level, and then the CHC probably pushes them to the higher district hospital levels. But in TB, for example, we obviously tell them preventive measures to be taken, and just the basic medicines which they take uh, every day, which every month, which they take for TB. So we do they have this it's like a calendar. It's they have like a calendar given behind their pills, where they poke the medicine once they've taken it. So we keep a follow up with respect to that. So we have either a ASHA worker going to the place, or we have the patient come to us every month. So we see if they have been regularly taking their medicines. That's the only way we do follow ups uh, at the PHC level. And as said before, like we push them to the CHC or the district hospital level if we think that, they need treatment at a fastened rate, or every person, like as I said, has their own way of being treated according to their stage. So that's how we follow up at the PHC level, at least.
Okay, so they definitely have a tracking down and make
Yeah.
sure. Actually, government is very active in tracking down the tuberculosis as in the contact and checking them. I'm sure that other people can shade on it. Nishant, you want to say anything about it with your take on this tuberculosis? Uh,
No, I mean, I think what you're talking about is really important, that getting healthcare, I mean, it's the last mile problem, right? And I think you see this in a lot of different industries and places. The reason why Amazon is so successful is they solve that last mile problem, right? It's like you don't have to go to a distribution center, you don't have to go to Target, you don't have to go to a store to pick up the product. It comes to your house. That finishing the last bit of service delivery to the person's home dramatically changes the ability to detect cases. And in an epidemic or a endemic disease like tuberculosis, that's essential, right? Because unless you find every last case, you're going to continue to have transmission, and you're going to continue to have an endemic disease. So whether it's malaria or COVID or tuberculosis, it's the same issue. And I think having a financial model that incentivizes people to complete that last mile of service, so that even if the patient doesn't come to the PHC, even if a doctor's not available at the PHC, there's still the ability to identify that case in the household is essential and important. And I think that's the design of the program matters, because you can have social workers and community health workers and ASHA workers in the health center, but if they don't leave the health center and go to the person's home, their role is limited. And I
good.
think that's kind of the unique aspect of this kind of program.
Good thing about Nishant brought, and one of the interesting part in India, even right now it persists, even among us, we are all educated. Those who are physicians do not appreciate and acknowledge and also respect the role of everybody below the physician, whether it's a nurse, whether it's a technician, or even ASHA worker. All of these things are part of the chain, and they are as important as one head honcho at the top or physician. Just like here, the surgeon feels that I am the person who makes everything happen. But yes, everybody should play the role. So respect, compensation, and dignity is very, very essential, which I still see in India. We have long way to bring that up. People also kind of used to it And so that's barrier has been, we have not come out of that kind of mentality fully. Yes, there is definitely improvement, long way, but that's a good point. I think so. We will turn over to Kriti. Let her take over now and talk about her topic. Go ahead, Kriti.
Hi, good morning, everyone. So my presentation definitely won't be as exciting as the presentation we just had. I'm just trying to share. Can you all see my screen properly?
Oh, good. Yes.
Okay, perfect. So what I'm going to be talking about today is actually a SOAP note. And if any of you have worked in a healthcare setting, you probably are familiar with what a SOAP note is. So when I was thinking about topics to really talk about during this externship, I really wanted something that you guys could use not only for this specific experience, but also after leaving the internship and, moving on and working in healthcare. So just briefly, a SOAP note is basically a documentation that basically all healthcare providers use. It kind of just shows you a format. It shows you it's just kind of a format that everyone uses, and it's something that's very standard, and it's something that I didn't know about until I started medical school, and it's definitely something that you learn. But I think that getting you guys a skill early on, or at least dabbing your toes into it a little bit early on, is going to be really beneficial, especially if you all are in college. So if you guys are going to work as medical scribes or even just shadowing, anything like that, I think you'd really wow whoever you're working with if you kind of have an idea of the structure of what a SOAP note is. Okay, let me just see here. All right, so a little bit about me. I'm a third-year medical student in New York, currently doing my clinical rotations. I'll just start from the beginning. So I completed my undergraduate degree at UMass Amherst in microbiology. And during my senior year, I actually went on the internship to India, and I have some pictures to share from that. I took a gap year before starting medical school. I worked in a primary care office, and now I'm here working at outpatient pediatrics clinic right now, doing COVID swabs all day long. So it's very real. That's just very briefly about me. These are some pictures actually from our trip. You can actually see Dr. Hasmukh in this picture right here. So this picture is actually when he went to the village, and the villagers had this huge, they had these dances and songs for us that they were sharing. These are some of the other people I went on the internship with. These are all the kids. We were explaining to them we came from the plane in the sky that they used to see. And this picture is actually, we all scrubbed in to see a cholecystectomy, which is the removal of a gallbladder. So we were all able to scrub in on that surgery. So just a few little pictures. Hopefully, Dr. Hasmukh, it jogs your memory from when we went as well, back in 2016, December.
Oh, wow. It's in the countryside. Oh, yes. Good.
Yeah,
Good.
so yeah, all these pictures from that. Yeah. Okay, so I have a video, and I really hope it plays. I hope you all can.
Hello, welcome back. Today we're going to talk about SOAP notes. This is just the basic introduction to SOAP notes for those interested in or about to work in healthcare settings. The SOAP note is really used for documentation and communication. We document an interaction with the patient so that we have a record of what happened. That record then becomes part of their permanent medical records. We also document to communicate with our future selves and other healthcare team members that might need to know what's going on with the patient. SOAP notes are used across many disciplines within the health services. The information and length changes depending on the situation, but the basic structure remains the same. Today, we're going to talk about the basic SOAP note structure and what a medical SOAP note would look like. There are 4 main parts to the SOAP note, and each part has a couple key subparts. Luckily, the name SOAP is an acronym and reminds you what those parts are. S stands for subjective, O for objective, A is assessment or what you think is going on with the patient, and P is the plan of action. The subjective section of your SOAP note should contain information gathered by talking to the patient, the family members, and the medical record review. Depending upon the nature of the encounter, it may include any or all of the following sections I've listed here. In a comprehensive or really expanded SOAP note, most often called a history and physical, You will review and document all of these sections. For more focused notes, like post-surgical progress notes or sick visits, you'll include only those sections that are important to the encounter. Remember, the O stands for objective. This is where you record your physical findings. This section should not contain anything the patient has told you. Note only your objective observations. Also, you may use information such as age and laboratory and diagnostic test results, but remember, it's just the facts. This section should contain notes about the patient's general appearance, their vital signs, and findings from the systems examination, like eyes, ears, nose, and throat, cardiac, and respiratory. The amount that you review and document really depends on the reason you're seeing the patient. Moving on, the assessment portion of the SOAP note is really based on the information you gathered in the subjective and objective sections. So it combines all the information you have so far and allows you to be able to decide what you think is going on with the patient. Depending on who's writing the note, the information in this section could be left as a general statement of what might be going on, or it could include more detailed information like the differential diagnosis and a list of billable medical diagnoses that you're seeing the patient for today. Finally, the plan is where the writer gets to decide what to do. This can include ordering or requesting consultations. If it's a medical clinician writing the note, then it may include prescriptions, treatments, and diagnostics like chest x-rays. It could also include patient education and anticipatory guidance. And then directions on when the patient should follow up are also really important. Okay, so now you know the basics of the SOAP note. So let's go through an example and put this all together. Today, we're going to see Mr. Fred K. Aloha. He's a 62-year-old male who brings himself to the clinic complaining of a sore throat. So let's walk through and actually write the SOAP note. The first part is a summary of what the patient tells you. When you document, you want to be concise and only summarize the important information, like the timing and severity of the symptoms and any other symptoms that are or aren't present. So I'm going to document that Mr. K. Aloha is in today with a sore throat. That's going to be the chief complaint. The history of present illness, or the story of the chief complaint, is going to start with, he is a 62-year-old male with a history of hypertension, and he presents today with 6 out of 10 constant pain, worse at night, started 2 days prior to the visit. He has associated symptoms of fever, Tmax of 102. He denies headache, rhinitis, congestion, sinus or facial pain, nausea, emesis, cough, or shortness of breath. I know from reviewing his chart and confirming with him that he has already had his flu shot for the year, and he is still on lisinopril 10 milligrams for hypertension. He has allergies to sulfa drugs. He doesn't smoke, only drinks socially, and denies illicit drug use. You notice that I didn't put anything in about his social or family history because that's not really pertinent to this case. Let's go on to document the examination. The vital signs include a heart rate of 77, respiratory rate of 16, blood pressure of 158/92, and temperature of 100.3 Fahrenheit. For the general survey, I commented that Mr. K. Aloha was an elderly male, alert, and in no apparent distress. His eyes, ears, and nose examination were all normal. His throat, however, wasn't. The back of his throat, called the posterior oropharynx, was red and inflamed. His tonsils were hypertrophied and had a moderate amount of white exudate, which is the medical way of saying he had a bunch of white junk on big tonsils. When I examined the lymph nodes in his neck, I noticed tender anterior cervical nodes on both sides. His heart and lung examination were normal. Based on all that information, I can make my assessment or my diagnosis. Starting with the global assessment, I summarized that the patient is a 62-year-old male with a history of hypertension who's in today with sore throat. Clinical picture suggests streptococcus pharyngitis due to 4 out of 5 points on the modified center criteria. Differential diagnosis includes viral pharyngitis or retropharyngeal abscess. I'm going to diagnose him with streptococcus pharyngitis and also uncontrolled hypertension. Next, you get to develop the plan. For his throat infection, I'm going to prescribe penicillin VK 500 milligrams 3 times a day for 5 days. I'm going to have him continue supportive care with salt water gargling, Tylenol, and ibuprofen for pain. There aren't any labs or consultations needed. I'm going to have him follow up in 3 days if no improvement, sooner if the symptoms worsen. For his hypertension, I'm going to increase his lisinopril from 10 milligrams up to 20 milligrams because he's not yet to goal. So that's the basic structure of the SOAP note. Subjective, or what the patient tells you. Objective, what you see. Assessment, what you think is going on based on the subjective and objective information, and the plan, what you're going to do about it all. I go into this in more detail for the nurse practitioner students.
Okay, so
Oh, good.
Hello,
Good.
welcome back.
all right, so that was a lot of information, especially if you guys haven't worked in sort of a clinical setting. That was probably like too much information. And the reality is that based on who you're working with, if it's the doctor you're working with or the clinic you're working it with, people really make their SOAP notes differently. And when they teach you in medical school is a very specific way, but then the reality working in a hospital, they make them differently. So the truth is SOAP notes do vary, but the basic structure remains the same. The subjective, objective, assessment, and plan, that still remains the same. So I don't expect you guys to make any diagnoses or know how to do the plans. So I don't expect that. But I really think the subjective portion, really understanding what the patient is trying to explain to you, is something that you all can do easily before being in medical school. So I really just wanted to start with introductions. Now, this might seem really silly, but being able to go into a room and kind of introduce yourself properly, it really demonstrates a level of, maturity, and it kind of just sets the goal and standards within the room. So you'd really, this is really how you would introduce yourself. Hello, I'm student doctor. I will be working with Dr. Usman to help you today. Just kind of sets the goal and kind of just tells the patient, who's this random person in the room. And of course, something that is very important in the United States, especially that I've noticed, is being able to ask the patient how they would like to be called as. As you guys know, these days there's many different ways that people like to be referred as, whether, there's many different ways. So it's really important, especially if a patient is coming to you with maybe some more of a private issue, you want to make sure they feel comfortable opening up to you about whatever is going on. So you always want to ask, how would you like me to address you? And these things might sound really silly, but I've heard from plenty of patients that the way you show that rapport, it really lets the patient open up to you and they feel, they feel comfortable around you. So don't just assume based on their chart, that's what they like to be called. Just kind of ask them how they'd like to be addressed.
Mhm.
Okay, so the first part, like in the video was showing, this is a subjective, okay? And so we're gonna go through every single one of these because like I said, the subjective portion, I think all of you guys can get a really good grasp on. And like I said, it's gonna wow the future doctors you work with on your interviews, things like that. It's a really big wow factor. So I think that this is something you guys should be able to take away after today.
Mhm.
So the first thing is really the chief complaint, right? It's the main thing that someone's coming in for. I have a headache, I have pain, I'm feeling nauseous. It's really simple. And sometimes when a patient comes in, they come in and they have like a whole list of complaints, and really being able to jot it down to like the primary complaint is very, very important. And don't mind my little memes. I just wanted to make it a little bit more exciting. So just enjoy my little humor.
You can summarize a little bit short this one.
Yeah, sure. So then the HPI is just we're kind of extrapolating on what the patient is talking about. So this is kind of the way that an HPI is done. It's using the mnemonic OPQRST. And it's basically the way you expand on what the patient's chief complaint is. So here you can see based on the chest, if someone's complaining of chest pain, how you kind of would break down what they're complaining about, and being able to kind of understand more of that specific complaint.
Yeah, I think we are going more in detail, so we may
One-
not have to go in detail.
Okay,
I
sure,
think.
sure. So then the review of systems is just, you guys don't need to know this, is just all the different systems in the body and specific questions you can ask. Okay, and then medical history is, anything they've been diagnosed with in the past, if they have issues with their thyroid or diabetes, things like that. And then healthcare maintenance is something that's really important here, but it should be everywhere. Just routine things that people need to get, like mammograms, pap smears, colonoscopies, things like this. It's very important to make sure you're following up with your patients on this. And then of course, family history, right? You want to know if there's any history of cancer, any chronic illnesses. Okay, and then social history is something that's also really important, and they're the more the touchy topics that people don't really like to talk about. recreational drug use, smoking history, things like that. And this can actually be really helpful to be able to understand, kind of give you actually good differential on what some patients might be dealing with based on if they have a really severe smoking history and things like that.
Oh, wow.
And then just your surgical history, which, that's fine. And of course, any allergies, these are probably questions you've all have heard at your doctors, but this is the way that they actually format it. And then of course, your objective, right, as I was referring to, is really your physical exam. And this is just an example of a physical exam that was done on a patient. We can go through it if we want, but this is just kind of to show you the way we do like a head to toe exam on a patient. And no one expects you guys to know how to do this. And I'm still learning how to do it as well, how to do a proper physical exam and focused physical exam. This is just showing kind of understanding how this patient has complaints, feeling tired all the time, but really she has complaints that's showing us hypothyroidism.
Wow. Wow, that's good. We did it.
We did it. So based on doing a physical exam on this patient, we were able to kind of, our assessment, right? So what we think is going on with the patient, we're able to bring down our differential to things like hypothyroidism, Hashimotos, which I'll explain briefly later what that is, diabetes, and depression. And then the plan for this patient whose actually symptom was complaining of feeling tired, and she showed a lot of things that related similarly to like hypothyroidism. We were going to be doing blood tests to look at TSH, a sonogram, like an ultrasound of her thyroid gland, and also her hemoglobin to check to see if she has diabetes. So just really briefly, I know that this is a lot of information, just a little bit of clinical information because I really wanted to share that with you guys. So just hypothyroidism, if you guys don't know, it's really when you don't have enough thyroid hormone. And so this patient was complaining of feeling fatigue, and she actually also complained of weight gain and hair loss. And those are some of the few effects that hypothyroidism can have on the body, along with weight gain and menstrual changes, things like that. So you can kind of see the way that your thyroid works and why we're specifically checking TSH and T4. There are these hormones that based on the results, we can really tell if someone is having a hyperthyroid or hypothyroid. So I'm sure if you guys have taken biochemistry in college, you guys know all about negative feedback, positive feedback, all these wonderful things. And so TSH and T4 is kind of works in the same way. But if someone has hypothyroidism, you're going to see elevated TSH and you're going to see decreased T4 because their thyroid gland isn't working properly to make these hormones. And then another quick thing is what is Hashimoto's. So Hashimoto's also causes hypothyroidism, but for a different reason, where it's actually more autoimmune and your body's actually attacking your thyroid gland. So again, similarly to hypothyroidism, where I explained there's going to be an elevated TSH, here there's going to be the same exact thing, but you're also going to have like autoantibodies against these things that aren't important to you, but in case you're interested. So the reason that I made this is really so you guys get a really broad overview of what it's going to be a provider, whatever you guys choose to go down the route, being a doctor, PA, nurse practitioner. There's so many different routes. This is really a standard way to format each patient encounter. And it really helps to break down, the patient can come in with 30 complaints, but it really helps to break down what the patient is specifically talking about. And it kind of just helps to organize your thoughts. And this takes a lot of practice. And not something you're going to get overnight, but I think that on this internship and even in the future, kind of having an idea of this will be really, really helpful to know how the doctor's thinking, because when they're thinking about the questions they're asking their patient, they're going through this SOAP note. So I just wanted to provide you guys all a little overview of what a SOAP note is. I did have this video, but it's a little bit long, so I don't want to bore you guys with that.
Yeah, we can stop here for a while and let's go from there. Okay, I think so. Let's get the Tanya, let everybody come on the gallery view. So you can, that one, I think so. I think so. Let me give you my 1 minute on take. What I learned from soap is in your life, even if you really give attention, then you are more comprehensive when you collect the information, how you kind of categorize and make sure, and then you can appropriately, you can ask the questions and get the more information. And it's back and forth between S and O. And finally, then you come the assessment. And then you also have plan of execution. So even whatever, and when may not be in medical college, but any other thing, this is definitely a very helpful way to think. We all, when we enter in the college and then we go into particular field, our way of organizing and actually assessing and executing is really helpful. So Kriti has given a medical version of it, but it is applicable in everywhere along. So let's take the questions. Anybody has questions? We want to hear from it. Divya, you want to say anything? Let's Divya given a uh, uh, or we
Yeah,
have a go ahead. We have a Dr. Seema Shah from Baltimore. She was with us. She is also MD MPH. Let's see, we can hear from her for 5 minutes. Seema, you want to unmute and give us, go ahead, Seema. You have been here for last 15 minutes. So you can unmute and tell us what's your take on it about whatever you have heard. Uh-huh. Uh, Go ahead.
thanks for sharing, Kriti. I feel like you gave a great overview. And like you said, there's definitely parts of the SOAP note that even if you haven't been fully trained as some sort of medical or health professional, the organization and structure is really important in communication, just like you do in other settings. So I really appreciate that. And then just learning how to gather information and present it in a very succinct way to others that still gets the message across. I don't have too much more to add since I had spoken to this group earlier, but feel free, again, I wanted to just make sure that, you know, if you all have any interest or opportunity or in connecting offline, I'm happy to be available.
Oh, wow. That is great. I think so. Let's have the question. Divya, you want to ask any questions?
Yeah, I have a question. So, has Soap Notes gone virtual in like America, and how are these conducted in the rural areas of India?
That's actually in India, very, unless you go to a practice in a consultant, like in a people who uh, give consulting firm, you can see that what they write, but their writings are not legible, so you cannot read what they are writing. But they basically use that format. Format is used, but not really. Here, interestingly, how this thing is very important, that you write, but you are sharing with so many people. You are giving to your nurse, it goes to insurance company, it also goes to available for record review, pharmacists get it, these people, that people, and it is very, very essential. So you do not make, you make an error, it multiplies. So it's very important that you do not error. Write what is needed, not to do elaborate, what called non-essential things. Yeah, there are certain things, negative are important, but it's very important for us. And more, as Kriti said, that in your life, what it does is that your what we call a observation power, it get more sharpened. So you look at whenever as a nurse, as a physician, or further up, you see what is essential and what is not essential. It's amazing. More you practice, better you get at it. So it's a good, Divya. That's a good. Uh, anybody else wants to ask question?
I had a question. It was kind of similar to Divya's, but I was wondering, like, when you went to India, what differences did you see in the format that the doctors there or like the Arogya Sevikas use to take notes compared to like the soap notes here?
I think so. We are still in a primary phase for Arogya Sevika. When Kriti was there, we were just launching all this Arogya Sevika program. Many of them only they keep a record of their age, uh, where they are, I mean, their family, what they are made of. Sometimes we don't know, but they live in a what they call a extended family. So they also important. They also want to know about it, their past history. A lot of time you don't ask, you don't get it. Sometimes they have 2 or 3 miscarriages and they will not know or not talk about it. Or they also how the husband is treating you. A lot of these things are not recorded there. All of that, but you get it out. Here in United States, you have right to record. But same time, it is kept as a HIPAA law that it doesn't allow anybody to have access. Those who are qualified have an access to it. And sometimes they may not access. In psychiatric, there's a lot of limitation that you cannot give all these things. Same with, I'm sure Sima can tell us, some of the time when you talk about some of the diseases, HIV, I remember that HIV test was allowed to be kept secret. Is that right, Sima? Before, you cannot tell anybody else. HIV test results were kind of kept. So we basically keep the patient's privacy, and sometimes we have to collect. In India, soap notes are not there at Arogya Sevika level. We have a long way to go. It does increase a big burden of record keeping, and now with electronic, it's all easy. But I still remember back 80s and 90s when the soap came. You have a lot of time consumed in recording this information and keeping. So the chart was getting heavier and heavier because it was paper. After 2000, the paper started going away. Good question. Anybody else wants to say? Devki, you want to say anything?
I have a question.
Go ahead.
Oh, so in asking like social history, is there a certain technique that you can use if you're trying to overcome any like cultural barriers or any stereotypes that they won't reveal information to you?
That's
Good,
a really
Kriti.
good question. Yeah, that's a really good question. So when we take a social history, we start off initially by saying, I ask all patients these questions. They're a little bit more sensitive topics. If you don't feel comfortable discussing certain aspects, I completely understand. You kind of give them this feeling of like, understanding. And so of course there's certain things that people don't feel comfortable talking about, and that's completely fine. But when you go into the social history aspect, kind of being open-minded and a very non-judgmental environment in the exam room, then I think that really can change the way that you'll see patients interact with you. And it definitely takes practice. So again, this isn't something that'll happen overnight, but just being very open-minded and kind of just always navigating that patient relationship very carefully.
I think so. That's a good question. Is that you go with open mind and empty mind. So that's one of those Buddhist way of mindfulness. So you are basically are a good listener, but also you do share their whatever. Takes time, and you build relate. That's where the primary care physician plays an important role, that you are there holding their hand and taking them through the process. And once you have the information, you don't have to ask again, because they are already in the record. So record keeping has also one advantage, that you don't have to go through all these things. You already have it and you built on it, and then you are more specific. It doesn't consume time after your initial, what they call extended visit or whatever. Good question. Devika, you wanted to say something? Devki, sorry. I always get it.
No, I don't have any specific questions, but thank you so much for sharing.
Good. Okay. Hardik?
I mean, I don't really got any questions per se. I mean, all the good questions have been asked, but I thought the presentation was really informative. I really liked it.
Yeah, I think so. We both have a, Nikita, have anything to, you can give your suggestion or question.
Yeah, I don't have any questions, but I thought it was really interesting because the OPQRST method and SOAP has been used like a lot for a lot of doctors I've shadowed and described. So
Good. Vanya, you want to say anything?
Yeah, I mean, I'm just curious, is SOAP notes, is it mainly used in the US as part of the US healthcare system, or is it kind of a universal method used all across the world? Not necessarily like in rural areas, but just all over.
Good question. Miss, I have not inquired about it, but there is some method of record keeping. Now, with many of the places, wherever there is records has to be submitted and insurance company have to pay for it. They have a system how to keep the record. So SOAP is here, but there is some format of it in rest of the world. Because when you go into journals, you can see how they describe. So
can Mr. Himanshi give some idea how they are introducing in India now slowly?
I don't know whether, go ahead.
So we do follow the SOAP pattern. It's compulsory for us to show our senior doctors whom we go to with a SOAP format. So we have the SOAP. Like Kriti said, that the first thing to be done is to create a rapport with the patient. So if we're talking only about the village level, we make sure that firstly we talk in their language, which is the key to make them feel comfortable. So we make them feel comfortable. We have a rapport created. The best thing said was that we go with an empty mind. So you do not react or you do not make any expression on your face with respect to whatever information you're getting. So we have a lot of things we do follow the same thing which she said. I don't know about every village or every remote area where we follow, but at least at places where I have been or where I have worked, we've done the thing which has been mentioned with respect to the PPT. And talking about the universal thing, so where I was studying in the Philippines, we had a very strict pattern to follow with respect to the SOAP, but it was just same as to what as what she showed in the video. So I feel it's more universal than just at one or two particular places. But the first thing, as said, that the rapport, or the first thing you do is greet and give an introduction about yourself, which actually gives them also a little information, and it's just that they feel more comfortable with you and not scared as to what the notion is usually.
That's a very interesting point she brought, because
one more question for doctor is sometimes the gender also makes a difference if the women doctor is talking to women patient, and the same reason sometimes religion also. How do they solve, especially in a rural area?
If there are no female doctors present and there's just a male doctor present, they have to make sure that they have another female or any family member of the patient along with them. And they take permission before checking the patient. So, for example, if we have to do an abdominal examination, may it be a female doctor or the male doctor, we first ask consent and then we go ahead with the steps we do, and we explain or we tell them about each step that we're doing, so they're aware of what we're doing as well. But yes, it's very prevalent with respect to the gender that they're not comfortable talking about a lot of things with a male doctor. And to be honest, the male doctor just switches and he just asks the female colleague to go if if they see that the patient is not comfortable.
Yeah, it's a big
But
challenge.
this is,
Go
yes,
ahead.
but this is just at the village level, as in at the village level. In the cities, it's just not the scene. Like the male doctor can be a OB-GYN and do whatever test a female doctor does as well.
Oh, good. I think it's a it's a very good question. Priyanka, you want to say anything, or anybody else can just jump into it?
I think my question was for Dr. Himanshi. I was wondering, oh, not Dr. Himanshi, sorry, it was for Kriti. I was wondering what were some of your takeaways from when you went on the ACLE externship program and how that's in any way impacted your experience in medical school, or anything that how it gave you a new perspective going into medical school.
Sure. So that's a good question. So I've always really liked learning about the way people outside of the United States live, different cultures, and being able to learn. I actually went on another type of like internship to Haiti, and so being able to kind of learn about how other people live, people who live without running water or people who live without electricity, things like that. It kind of, so currently in New York, I work in a community hospital where we see people from all around the world. And being able to have experiences that you can show that you can relate. You can't say you relate completely, right? Because of course the patient has their own experience, but being able to understand their barriers to access to proper healthcare, access to clean water, access to medication, kind of being able to understand that from different experiences that I had during my undergraduate really helps me to understand the patient better. And that's the best way I can explain it, is that seeing how people live outside of the United States is a huge eye-opening experience in itself, to be quite honest, especially if you've never experienced that before. And what I've noticed is working in women's health clinics currently and being able to see people from other aspects of the world and being able to understand, when they kind of talk about their barriers is really helpful. And it even, again, creates better patient rapport as well.
Good. I think so. Priyanka, you asked a very good, important question. And what I consider all of you, and even myself, I can remember, is that going out of your comfort zone, especially in your 4 years of college, and you have gone somewhere else where it's not the same culture. It is an eye-opener, it is a life changer, it is a transformer for everybody else. We become better human being, and we actually become somewhat more humble. So it's a good question, Priyanka, you ask. Anybody else? You can jump in, even though you are not video on.
I also wanted to say one quick comment as well. So similar to what Dr. Himanshi was saying, in India and the villages, when there is a difference between sexes. Similarly, here in the United States, there are also issues like that when it comes to for any religious reason, or, what may not be. So usually here, you'll see if it's like a male doctor, they'll have a nurse who they consider a chaperone in the room to just, monitor what the doctor is doing. It's a way to make the patient feel safe. So that also actually happens here as well. And it's something to make the patient feel more comfortable. And also, as being a provider, knowing that someone else was in the room also saves you like liability. So that's also something that's done here as well.
Good. I'm glad. Let's see. Anybody else has any questions or overall? Go ahead.
I mean, the presentation was great. It summarized basically 2 hours of every day of second year of med school. That's what we do. Yeah. And yeah, we spent like so much time learning this, and I was like, wow, that was pretty cool. And yeah, I just like I mean, from what like we do over here, it's basically because obviously there's a lot of time constraints just because of the number of patients. So S and O are like not clubbed together, but they're like considered one entity. So the complaints and then what he says. So it's like we just like alternate between the two to like save time. I think that they were asking something related to that. So
Good, Meena. I think it's a good point you brought. I think so. What I learned from this today's session is amazing how Dr. Bora has put us what is ground level happening in India. And Nishu has brought up that this is the last mile, which is government of India is also considered that one for almost more than a decade, the Asha worker program. Uh, Rush report came out in 2018. There are few things which were very interestingly brought into a, I think, interesting topic we have shared, Tanya. Is that right? And it says that a lot of time they're time consuming administrative work. And this is where always happens that sometimes the burden, because they want to verify and they want to document and things are not taken for granted. So a lot of time is wasted in that one. Second thing is that to have the people in the worker hiring, it's not easy because this is where the basic level of education in this country, as you look at it, people are not only sixth grade or seventh grade or primary education, they have middle school and then high school. Nowadays in this country, high school diploma is essential. If you want to get a job in Walmart, only job you can get is to push the cart if you do not have high school diploma. So this is very essential. What I found it, and the basic foundation is education, which is not just read, write, but to comprehend, and not only comprehend and go beyond it, that how you can make that education to put to use in your daily life. And here, Ekal wants to put this thing along with it. So in integrated village program, as we talked about on ground yesterday, this requires a commitment of few people at the village level that they basically go heart to heart and get connection heart to heart to make the villagers. And once you have enough, even 10, 12, 15 people, whether it's a youth or women, join that, then transformation. It's look like you have fire has ignited and now it will take its own. So I'm very, very thankful. Ramesh bhai, you want to comment anything in last
I'm
5 minutes?
okay. I'm not a doctor or medical field. I'm more of a social person. But what I appreciate, Dr. Himanshi, Kriti, even all of you, those who go to villages and see this thing, your heart vibrates for the common people. And for Dr. Himanshi like people to serve in a PSC is not a joke. It's not easy nowadays when every doctor wants to just be in a good place or big cities, big apartments, big house, whatever it is. But to serve is a big thing. And I think our program, what provides is that sense of social service and responsibility towards society, regardless of who they are, poor, wealthy, gender, whatever it is, religion, doesn't matter. And I think that will take this program well into next century to provide what we see in US, the differences and the discrimination. Those all things will probably will help us to understand and provide services. I really appreciate it. And I'm sure Mina will look more into details in India also how it is happening. But
I
I'm
think
glad. I'm happy. I learned a lot, honestly. I didn't know what soap was, but then it opened up my my own thought process, just a basic process. At the same time, what how fast she explained the soap, that was so fast, but so critical. And at the same time, Dr. Himanshi went through much more detail than we ever knew living in India or here at what Asha worker does and how they do. We appreciate really their service and their level. They're not paid much. Honorarium is not much. They're still fighting for the increase in honorarium. But this is what happens when human service and human care comes into picture. But I really
think
appreciate
Meena even is from India. I think she's born in USA, Meena.
Yeah, I was born
Yeah.
in US and I wanted to come to India. So
Okay, so she has a foot in both continents, so that's good. So I'm really Tanya, you want to say anything about it for tonight or anything else you want to see?
Tonight we will be looking at the awareness rally, and then we have a lecture on vector-borne diseases. And then tomorrow morning, Brajnaji will be joining us, and we will be learning a little bit about Ayurveda and meditation.
Yeah, I think it's a good thing about, she brought about that called Ayush worker. So in India, other healthcare is integrated beside what we call allopathy, which we all practice, myself and Dr. Kriti and Dr. Bora. We include the Ayush, and this is where certain things will be added by Pragnaji. So we will definitely end the session today. And all of you, thank you very much. Took the time on one of those Sundays, but hope the weather is over good so people can go out and take a walk. In Chicago, it's cold, but go out and enjoy the day. And we will see you again tonight.
Yes,
Okay.
remain safe, take care everywhere.
Okay. All right. Thank you.
Thank you.
Bye. Thank you. Thank you very much.